CMS interoperability APIs for the payers are looming over each of the payers' heads. I think most of the payers have been focused during this time on APIs that really focus on the way they operate today, like the prior authorization API. But that leaves things like payer-to-payer and payer-to-provider kind of on the back burner. Unfortunately, the time to address those things is quickly running out, and so we wanted to give a presentation on how implementation has gone in some specific instances, specifically with an eye on how we might be able to help those who are still coming into the fold. Let's take a look back first, a little back in history. If we look at the CMS mandates history, it originally was released as a completely different set of requirements. Later, it was rescinded, and then a new set of requirements were proposed, and it was not finalized until the beginning of 2024. Because of that, you can see on this slide all the standards that they're referencing were also shifting throughout that entire period, and the shifting is not changing. This is foreshadowing for the future. Now we're going to take a look at the actual requirements that CMS has for, this is specifically looking at the payer-to-payer API. I've grouped these things into two boxes here, and you can see in the red box, these are really oriented on encoding your data. And that's something that we've been talking about all throughout this conference. Encoding your data in a way that we have FHIR resources, in a way that we're using common nomenclature, that all makes perfect sense. But when you look at the requirements of this, it's that very last one that's the top in the blue box that's the only thing that gets into how do we authenticate with each other and how do we exchange that information that we'll be able to understand. One standard might be enough, but these other three in the blue box that are not required are all more granular than the required standard, and the fact that there's different options and it's not all required leaves a lot of people with question marks. I want to argue that authentication is the sleeping dragon. It's the thing that's keeping us from the treasure of having truly interoperable data. So if I'm a payer and I do everything right and I follow all of the recommended standards and I implement each piece exactly as intended, but another payer that I need to exchange with only followed the requirements and they don't support, say, MTLS because it wasn't required, now I have a problem and I'm going to have to adapt with how I exchange with that payer even though I did everything the way the standard went. So that really increases the need to have flexibility in the way that you authenticate and the way that you connect with each payer. Those things aren't the only place where we have insight to share with each other, with you all. And now I'm going to introduce my colleague here.
Hey, good afternoon, everyone. My name is Ranjan Saxena. I'm Principal Solution Architect at Humana. So we have worked on this peer-to-peer proof of concept. From a conceptual perspective, it looks pretty good that like the data exchange between pairs, patient data exchange between pairs, that makes sense. But we little bit deep dive further, and there are certain things or certain areas which we kind of bringing in front. Like one of the piece is the consent, which is very, very important, right? So because between peer-to-peer data exchange, there's no treatment relationship, so to say, which is usually drive the consent and the understanding of the consent from a patient or the member perspective. So when implementing the consent, that's a core piece of the mandate as well. We found like we are kind of summarizing here, like one thing is that lack of standardized consent management framework across pair. And that's a known, not to say problem, known practice that every pair has a different way to handle the consent when they are enrolling or onboarding the members, right? So that's one of the things, and when we are sharing the data across the pairs, that probably will be one of the challenging areas to solve. Other thing is that obviously the CMS mandate is from a federal perspective, yes, it's good, but like there are conflicting guidance or the mandates from the state authorities specifically for the Medicaid members and around those. So in that case, there are like many areas where how to implement it. Like if you follow the federal mandate, you may violate some of the other consent which are needed specifically for the states and all that. So that's another challenging area. The third is educating members on consent and data use. That's important because we as a healthcare community know what the interoperability means and what the data exchange means. But as a member, when I'm providing consent without any treatment relationship, then it's kind of like, oh my God, why I'm doing this thing. So a lot of education and mentoring and all those kind of things will be needed by peers for that. So it's more beyond the technical, how to provide the sufficient information so that members are okay to provide the consents. And obviously that technology and infrastructure barriers will always be there because, as you said, like as a pair, everyone has different kind of infrastructure and technology implementation of the around the consent. With that, the other part which we beyond consent, like exchange modalities, like obviously the mandate is like for supporting all, like bulk and the real time and the either all resources or specifying resources. It's good, again, conceptually from an architecture perspective, yes, that's very good. But implementing everything together by each and every pair, like 900 plus plans, will be a really challenging thing. So we anticipate that like there will be kind of like in phases, some of these implementations will go to comply also and not to like go beyond the compliance, but there will be some challenges around these modalities. The other challenges which are categorized as the general means like, for example, the patient matching and identity verification. This is very, very important because as we all know, there's no universal identifier for the healthcare members, right? So like every pair may have different member mastering, patient matching and all that. That leads to some of the challenges, right? Technological and infrastructure barrier, like for example, that as I mentioned, different pairs are using different types of the data exchanges, different API gateways, and different technology, how to support those kind of paginations, like all those kind of things comes into technological and infrastructure barrier when you are actually making the connection across different pairs. Number third is the data quality and interoperability challenges. Obviously, we are all in the firewalls from last like 5 to 7 years, all pairs. But what about the legacy systems, right? We still have the systems, like as a pair. We have the systems where the encoding of the data is not standardized. So that's where the data quality and some other challenges will come. Last but not least, data quality and interoperability challenges. The data quality is very, very important because like everyone is managing the data, so to say, in their own ecosystem. But when that data goes out the door to another ecosystem, the interpretation, it leads to many other things. And sometimes it may, some data is shared which should never have been shared, like the behavioral health and other things, right? So sometimes the data privacy and security and the other compliances will come. With that, I'll back to Michael.
Thanks. I did see at least one confused face, so I wanted to address the fact that if you came here expecting to listen to David Pike give a talk, apologies. He actually was at a stage over there about a half hour ago, and if you didn't know that, he told me to tell you, I quote, "You suck." So with that out of the way, going back into the presentation, within our cohort, we at Availity have about 3 payers who've been working together on implementing these pair-to-pair APIs. And within our cohort, here's some things that we've been able to identify. Number one is that it's taken us over a year for each payer. There's not any payer who is able to complete a implementation in less than a year. And so if you are a payer here today who is hearing this and you're thinking, we're waiting to start payer-to-payer because it's a small piece, at least 3 payers it took more than a year to get just one of these modalities working, the singles, when we talked about singles, bulk, and being able to query resources individually. The next thing we've been able to see is that we have got negative tests working in place, but we've noticed, I'm going to jump to beyond our cohort, and outside of our cohort, we are seeing a lot of places where there are not negative tests. What I mean by that is that if I'm looking at a reference implementation and I can use whatever patient ID I want and I get the same response back, yes, I'm getting the response I expected, but I can tell that you're not actually doing anything with the patient ID that I'm giving you. The final thing we've been able to establish within our cohort of payers is that, as I mentioned in my first part of the presentation, authentication is a big challenge. We had that trouble within our own organization because the recommended standards are something that our organization had never done before. We had to make significant strides in order to support these authentication methods like MTLS. And then beyond that, we've seen the exact same thing with each payer that we've worked with. And they've had similar challenges as to that. Other things that we've seen around the ecosystem, more authentication problems. We've seen a bunch of portals. I've been trying to reach out to different payers to see if they're ready to at least test with us. And in doing so, I've seen, 6, 7 payers that still have language referencing the old mandate that was rescinded, the CMS 9115, and we're now marching to the beat of CMS 0057. And so they haven't even updated their websites yet. And the lack of negative tests, as I mentioned. So I'm Michael Taylor. I'm the product owner at Availity for our payer-to-payer solution. And
Ranjan Saxena, Principal Solution Architect, Humana. Thank you, everyone.
And now we're going to pass the stage to our third counterpart here from Healow.
Thank you, gentlemen. Do you mind if I stand up?
Yep.
I think it makes it a little easier.
Sorry.
So I'm representing Healow and the Clinical Works here. I'm going to just give an overview of how we've implemented PDex, where we started, and where we hope to go in the future. Why we began this transition. I think if you guys are familiar with FHIR, you know a lot of these talking points within here. It's interoperable. I can connect with Humana. I can connect with Guidewell Florida Blue. It's the same standards, so it makes things much easier than working through custom formats. The standardization in there, the support for value-based care for the providers is huge. The providers love getting this data. They don't have to go to other portals for it. It's in their workflow, in their EHR. So it's a huge win for the payer, for the provider, for the patient. It's one of those rare win-win-win scenarios in there. Overview of kind of the flow of our data here. So Healow Insight sits in the middle. We are the cloud, and we connect to the back-end data sources at our payers, namely Humana in this case. Our current model, and I'll probably talk a little bit more about it, is a pull model, and it's based off appointments scheduled, so pre-visit planning can take place. But there's gaps in that, right? If you're only waiting for an appointment to be scheduled, you're not necessarily getting data for every member in your database there, right? We also close this, so it's a round-trip workflow. We don't want to just get data in, we also want to get it back out, so it can be ingested by the quality teams, the risk teams, and ingested into their payer FHIR ecosystem. So where we started here, we initially started in 2018. We got our first practice live. That was through a RESTful API, okay? By 2023, we had 350 practices on that RESTful API with the bidirectional exchange. The nice part with us is, since we're the cloud, the payers don't have to connect to each and every practice and database. They connect one pipe to us, and we fan out across the databases there. We piloted, this happens to be with Humana, PDex in 2023. As of maybe a couple weeks ago, 2,964 practices were connected with PDex with that bidirectional exchange of data. There were certainly challenges along the way. The simple fact that we did start with that RESTful API meant we had practices getting that payload and getting information, and moving to PDex, we may have lost some of that if we didn't kind of work on some, sadly, customizations that eventually we might get back more to the spec, but providers didn't want to lose that valuable data they were getting. And there were limitations within the Fire IG there. There's been challenges with, the throughput. How fast are these coming in? I think we've solved all of those now, but there certainly were challenges at the beginning. It's much easier to parse this data. Once we have that ecosystem in place, it makes more sense. We have a lot of teams that do work on it. We're envisioning further use cases down the road, further Vinci IGs. I would recommend staying ahead of deadlines. I think they really hinted at that for the folks that weren't ready or updating their websites, but it's important to get started. In terms of where we want to go from here, we're working on getting bulk APIs. Getting to the bulk will kind of solve that problem of that pull model. It'll be more of a push model, so we know that every member in that provider database has the most up-to-date information from the payer at that time. Right now, we need that appointment, or they have to manually request it. We plan on adding 2,000 more practices with Humana by the end of the year. We have, I think, 5 or 6 other payers that we're working with on implementing, and some of them are choosing the RESTful API route first. They're not all jumping right into PDex. Because of Smart on Fire ecosystem, we've also been able to launch Smart on Fire apps in non-eClinical work CHRs. So if you do think back to that data flow I showed you, that's still that one connection from the payer can now source that data to any Smart on Fire app in an ONC certified EHR. So that's a big win for the payers, that they don't have to work with every EHR out there to make their data available. We definitely want to look at the DEQM and CQL Fire use cases as well, because I think that will streamline the reporting and getting that data back from the payer to the provider, especially around compliance for quality measures, where we don't want that data to be stale when the provider's seeing it. We have other teams kind of looking at additional Fire capabilities that our work here has allowed us to do. We don't necessarily need to go into that a ton, but if you want to talk more, you can visit us at our booth and we can kind of dive into that a bit more. I think that's kind of all I wanted to communicate with you guys. It's definitely been a journey. I remember that first RESTful API showing up in that provider in Tennessee's first patient popped up. It's a good feeling. But we got to do more. So we're always looking to push it. We're always trying to talk to new payers to get them on board, because the providers don't necessarily want to get this from a handful or small percentage of their payers. They're now starting to expect it from all of them. And they're really our best resource for kind of getting some of these other payers that are a little slower going. Ooh, thank you for your time.